see now this recording point?
Yes, it is started.
Yes.
Alhamdulillah. So because there was some problem with that is why I shifted. All right, Bismillah ar-Rahman ar-Rahim. We go to our last two lectures of the motor system. Because this time was for tutorial, and now we will not have time for tutorial. So I will send the tutorial to Saleh. It will be like I sent you the tutorial for introduction. There will be small questions and answers. Please prepare the tutorial 100% because your midterm is very near. So inshallah, most of the questions, they will be from the tutorial, and 100% questions, they will be from the slides. No question out of the slide. All right, so the last lecture, it is about spinal reflexes and liens affecting the motor nervous system. Now, we will discuss some diseases which are related to the nervous system, motor nervous system, and we will discuss the reflexes. Ready? Bismillah. All right, so if you remember, we discussed two types of movements, one which are called reflex movements and the other which are called goal-oriented movements. So we will have a discussion about that, very small discussion. But then we will have detail of the different types of spinal reflexes. Then we will discuss the diseases or the famous liens which affect the nervous system and which you will be receiving as a physical therapist. And we will have one line about physical therapy in each of them. In between, we will discuss small topic about control of balance or equilibrium and the control of different things by hypothalamus in our body. So this is just a review slide of what we discussed at the beginning of the motor system, that we have two types of movements, one which is called reflexive movement. This is involuntary, and it is an immediate involuntary response to a stimulus. And if it is originating from the spinal cord, then it is called spinal reflex. I will give you an example. For example, in our eye, we have got the pupil, bobo. If the light is more, this becomes small. If the light is less, it becomes big. This is called dilatation and constriction of pupil. But this is not spinal reflex. This is by the cranial nerve. So what I am saying is this, that a spinal reflex is a reflex which is involving only spinal cord. Now, the second type of movement, they are called goal-directed movement. See, reflexive movements, they are involuntary. Goal-directed movements, they are voluntary movements. Here we can choose the time, direction, and extent of the movement. For example, I want to hold a pen and I want to move the pen to write something. I want to write Ahmed on a paper. So I know I will write R and Hamza and Ha and Mim and Dal. So yani, this, I can choose the time, direction, and extent of the movement, going to very simple or very complex movements. But they are not involuntary, they are voluntary movements. So they are called goal-directed movements. So reflex is an immediate involuntary response to a stimulus. And a spinal reflex is a reflex activity that only involves the spinal cord. Now, what is a reflex arc? Arc means course. So what is a reflex arc? See my hands, and then I will give you description over here. This is 1, 2, 3, 4, 5. Stimulus received by the receptor. This is number one. So the first thing in the reflex arc is receptor. Number two is the sensory neuron, which takes the message from the receptor to the spinal cord. This is number three. And then we have got the motor neuron or the efferent neuron, which is going towards the effector. What is effector? Effector is the skeletal muscle in our case, because we are discussing motor system. So my dears, this is called a reflex arc. Now, here at place number 3, we can have one synapse. If there is one synapse, this will be called monosynaptic reflex. If we have more than one, like 2 synapses, it will be called disynaptic reflex. If we have got multiple synapses over here in the spinal cord, this will be called polysynaptic reflex. And we will discuss these 3, inshallah, in a short while. So first, what is 1, what is 2, what is 3, what is 4, what is 5? So we have got the receptor, we have got the sensory neuron, which is also called efferent neuron. We have got integrating center or the spinal cord, and we have got the motor neuron, and finally, we have got the effector. So this is called reflex arc. Now, as I told you that at this place, we can have 1 or 2 or many synapses. What is a synapse? Synapse is a junction between 2 neurons. So if it is just 1 synapse, it is called monosynaptic reflex. And example is muscle stretch reflex. So this is typical question which we give in the MCQs. What is a disynaptic reflex? If it involves 2 synapses, then it is called disynaptic reflex. Inverse stretch reflex is an example of the disynaptic reflex. What is a polysynaptic reflex? If more synapses are involved in a reflex, and example is crossed extensor reflex. We will learn this, we will learn this, we will learn this, inshallah, in the next 10 slides. So once again, a little detail, we have got somatic reflexes and we have got postural reflexes. Somatic reflexes can be superficial reflexes that are having the receptors in the skin or mucous membrane. For example, I smell food and my salivation starts. For example, something is put on my tongue, I taste it and salivation starts. And something touches my skin and there is local vasoconstriction, for example, or there is local vasodilatation, superficial reflexes. What are the deep reflexes? For the deep reflexes, we have got receptors that are deep in the muscles or tendons. Our today's discussion will be mainly deep reflexes. They are very interesting because in our medical profession and in our allied medical sciences, we need these reflexes, and especially in neurology cases, which make your 99% cases for physiotherapy. Then we have got postural reflexes, the reflexes that act against jazibiyya, gravity, to maintain the body in an upright position and body balance. Like I move, I walk. So there are some reflexes which help me maintain my posture. What is posture? Posture is position of different parts of the body with reference to different joints. Now, as I told you, now we are discussing these examples and one more. So this. So one by one, we'll take them. What is myotactic or muscle stretch reflex? Now here, when this muscle is stretched, and we'll have a second diagram, that is why no problem. That is why we wanted it to be a little shorter so that you don't waste time on it. If this muscle is stretched, the muscle spindle, which I discussed last time, it records it. And the message is sent to the spinal cord, and immediately there is shortening of the muscle. So this is muscle stretch reflex. It is the simplest reflex. It is monosynaptic reflex. What is the receptor? Muscle spindle is the receptor for this reflex. What is the stimulus? So stretch of the muscle is stimulus for the reflex. What is the response? So contraction or shortening of the muscle is the response. What is the physiological significance? It contributes to the resting muscle tone and it increases the voluntary muscle contraction. And what is the clinical significance? It is used in the diagnosis of neurological diseases. Up till here, you are confused. What am I discussing? I am discussing muscle stretch reflex, which is monosynaptic, and its receptor is muscle spindle. But what is this reflex? This is the famous knee jerk or the patellar reflex. Everyone knows about it. If we hit this place, which is patellar tendon, listen carefully. If we hit this tendon, which is called patellar tendon, which is coming from this big muscle, which is called quadriceps muscle or quadriceps femoris muscle. So if when I hit it with this hammer, this muscle is stretched, it becomes long. When it becomes long, this receptor muscle spindle, it picks up the message from here that there is some change in the length of the muscle, and it is possible that the muscle breaks. So it immediately sends the message to the spinal cord, and alpha motor neuron, it immediately causes contraction or shortening of this muscle. When this muscle is short, our leg, it goes in front like this. This is what we call knee jerk. And you see most of the doctors, they do it to test the nervous system. We discussed it in the upper and lower motor neuron lien, that in upper motor neuron lien, the reflex becomes very powerful. And in fact, in the class, I did it with you. And then if there is lower motor neuron lien, that is this nerve is cut from here, then there is areflexia or hyporeflexia, that is reflex is absent. So on this reflex, I took more time just because I want you to understand what is the possible questions over here, and you have a clear concept. Now, this is about the quiz. Now about learning. You should know how to perform the knee jerk. And last week when you had your lab, you just have a look at this. So please read it carefully. This is known as patellar reflex or knee jerk. We evaluate lumbar 2, lumbar 3, and lumbar 4 segments of the spinal cord, if they are working fine or not. We make the patient sit on the examination table or the chair with their legs dangling freely. Yani the foot should not be on the floor. It should be hanging. The knee should be bent at a right angle. We locate the patellar tendon. We feel where is this place. We locate the patellar tendon, which is located just below the patella. You can feel it. You can usually feel it as a thick band running down to the tibia. Then we strike the tendon with a reflex hammer. This is called reflex hammer. So we hit it. When we hit it briskly, the strike should be firm but not very painful. Don't break his knee. Then we observe the response. A normal response is a quick extension of the lower leg. You see, when we hit it, immediately there is extension. Immediately there is extension. This is called reflex. So this is when we finish with it, then we go to the other leg. So this is called symmetry check. It's useful to compare the reflex on both sides to ensure that they are same, because it is possible that one side of the brain or one side of the corticospinal tract or one side of the lower motor neuron, yani on one side, it is damaged and the other side is fine. So this helps us immediately. If the two sides reflexes are not equal, this makes it, disease is there. My dears, let's go to the second one. You see, coming back to this, now we are here. Disynaptic, inverse stretch reflex. So here we have got a weight lifter. He tried to lift this weight, but when he went up, because the weight was so much that it made a lot of tension in his muscles. What did I say? Tension. In this reflex, I discussed the length, but in this reflex, I discussed the tension. So when the tension in the muscle increased, the receptor, it thought that the muscle will break from the tendon. It is a different reflex. It is a different reflex. It is a different receptor. Remember, here the receptor was muscle spindle. Now for this reflex, the muscle spindle is not the receptor. The receptor is Golgi tendon organ. And I'll come back to this slide in a minute, inshallah. Anyway, so immediately the muscle, it stopped functioning. Strange. The muscle stopped functioning. Just 3 or 4 days back, a weightlifter lady in India, she died because of this. Yani the weight she was lifting, it fell on her neck and her neck broke, because the muscle reflex was trying to protect the muscle and the weight was more and she could not balance herself. See, this weight is also falling on his neck and he is in pain. So inverse stretch reflex, it is a very useful thing. 1, 2, 3. Neuron from the receptor. What is the receptor? Golgi tendon organ. It immediately sends the message that the tension is more than what I can handle. This is 1, 2, 3, 4 weights. This person is trying to pick it up. So this tension in this biceps muscle, it increases. Immediately message goes, I cannot handle it, muscle tendon will break. So immediately the motor neuron is inhibited. This is inhibited. So the contraction is stopped and the muscle immediately relaxes. This is to stop the muscle from breaking from here, from the tendon. So the weight, it falls down. So these steps are here. Prepare them for quiz as well. When the weight is more, the tension is recorded by Golgi tendon organ. Motor neuron is inhibited, muscle relaxes, and the load is dropped. This is called inverse stretch reflex, which protects the muscle from excessively heavy loads by causing the muscle to relax and drop the load. Put a mark on this. This is your MCQ, but detail is on the next page. Inverse stretch reflex is a disynaptic reflex. The receptor is Golgi tendon organ. Stimulus is increase in the muscle tension by excessive stretch, for example, by lifting the weight, or by excessive active muscle contraction. What is the response? Response is the relaxation or sudden inhibition of the contraction. What is the mechanism? Mechanism is inhibitory interneuron leads to inhibition of alpha motor neuron, supplying the muscle that has got more tension. What is the physiological benefit? It regulates the muscle tension and protects the tendon from tearing. We come to our third reflex, withdrawal reflex. We touch something hot, we touch something painful, we touch something which is, causing some harm. Immediately the sensory nerve, it gives the message to the spinal cord. See, now here, 1, 2, 3, 4, maybe many synapses, they are involved. So this is not monosynaptic. This is not disynaptic. It is polysynaptic reflex, which give the order, number 1, all the muscles, immediately function. Our action is to remove our hand from this hot thing. So because remove in English, it is withdrawal. So we remove our hand. We remove our leg from painful stimulus. So this is withdrawal reflex. So again, when we experience any painful or damaging stimulus, immediately the message is sent, and this message goes to the spinal cord, and this then sends the message to the muscles, which withdraw the hand or the foot from the painful stimulus. This is called withdrawal reflex. It is a polysynaptic reflex. Its stimulus is painful stimulation of the skin or subcutaneous tissue or the muscle. It has 2 responses: stimulation of flexors leading to contraction, reciprocal innervation, which leads to simultaneous inhibition of antagonist leading to relaxation. Yani, if the hand is to be flexed, it makes, number 1, see, 2 nerves are coming. Number 1, it makes the flexors flex. Number 2, it makes the extensor relax. So put here number 1. This is number 1. Biceps or flexor contract. And here number 2, extensor, it relaxes. So my dears, these 3, they were examples which we discussed for the 3 types of reflexes. Then we have got a special type of reflex. This is called crossed extensor reflex. Yani subhanallah, we feel a stimulus here on one leg. This is one leg, this is second leg. Say this is right leg, this is left leg. The right leg is feeling the stimulus, for example, pain or pressure. the message goes to the spinal cord, many synapses. It also crosses to the opposite side. Yani this is now not on the same side. It goes to the opposite side as well. One limb, now this, see, the color has changed. What is the response? Now this foot, it is withdrawn. And this foot, its texture is changed. It is going into a second shape. So flexor muscle contracts, point number one. Here, flexor muscle relaxes. That is on the other side of the body. If this is right leg, flexor muscle contracts, extensor muscle relaxes. And this is the left leg, flexor muscle relaxes, and the extensor muscle contracts. Yani this is exactly opposite to what is happening on this side. I go back, it is same reflex, but this is on one side. This is withdrawal reflex, where we had biceps contract and triceps relax, or flexor contract and extensor relax. Here, we have got the same reflex, this contracts and this relaxes. But other limb also, it is opposite. Flexor relaxes and extensor contracts as compared to flexor contract and extensor relax in the other limb. So opposite extremity, this is also involved. Injured extremity, this is also involved. The name is crossed extensor reflex. And the detail which I told you is here. It is a polysynaptic reflex. It is in response to pain, pressure, and touch, tactile stimulus to a limb. Two responses, but in the opposite limbs. Flexion and withdrawal of the painfully stimulated limb. This is called flexor reflex. Extensor of the other limb. This is called crossed extensor reflex. The mechanism is reciprocal innervation, which takes from one limb message to the other limb. One flexes, other extends. The first one extends, the second one flexes. What is physiological significance? It helps in supporting us. It helps in maintaining our posture. So this was the dry part, and now we'll have the enjoyment part. We'll go slowly. What are the physiological significance of spinal reflexes? So number one, I start from here. Protection. Most reflexes, they are for protection. They protect us against injury. Number two, they help us in our tawazun, posture and balance. Number three, they help us in coordinating our different movements. Like when we are walking, we are becoming disbalanced all the time. So the reflexes, they help us balance our body. Then we have got developmental functions. A small baby does not have fully mature neurons, does not have fully mature motor functions. First day, second day, they cannot move their limbs much. After a few days, they start moving their legs and their hands. After a few weeks, they start holding things. After a few months, they start sitting up. So this means that motor system slowly develops. And by 1 year, mashallah, most of them, they are standing and they start taking small steps. And I don't go into detail that gradually our motor activities, they develop. So these are developmental functions which depend upon different reflexes. Finally, non-spinal reflexes, we have got homeostasis. Yani they maintain our internal environment by protecting us, or by functions like, we eat food and there is salivation, food reaches in the stomach and there is gastric secretion, there is fat in the diet and there is contraction of the gallbladder. So there are hundreds of this type of reflexes which are required in the homeostasis. Anyway, physiologically, they are very important. But now we come to most interesting thing, clinical application of the stretch reflexes. I go to point number 2. we have got tendon jerks and muscle tone, which help us, in the tashkhis and diagnosis of different diseases. And we just now discussed the knee jerk. This is the best example, and we'll have a couple of other things in the next slides in which I will remind you what we discussed in the upper and lower motor neuron liens. Physiological significance, the same one, but in short 2 lines. They help us, reflexes help us in maintaining muscle tone, and they improve the quality of our voluntary muscle contraction. What do you know the names of some diagnostic reflexes which doctors use in neurology? And this is percussion hammer. So he is doing a reflex on this muscle here, which is the actually tendon from the biceps. So biceps reflex, triceps reflex. In the ankle, we have got Achilles reflex. On the abdomen, we have got abdominal reflex. On the foot, we have got plantar reflex, which is the same name as Babinski reflex. In the knee, we have got patellar reflex. So there are some of the examples of diagnostic reflexes, although there are many, many others as well. For example, a doctor puts light into the eyes of a patient and sees whether the pupil had become constricted or not. So this is telling that the cranial nerve supplying the pupil, it is functioning normally or it is not functioning normally. We change the topic and we move to 3 slides for this topic and 1 or 2 slides for another topic, which will be our last, topics to finish with the motor system before we go to some of the diseases and their review. Now, one of the big functions of the nervous system is equilibrium, which in simple words, we call it balance, or we call it tawazun. So the state of balance is where opposing forces or influences are equal. Jazibiyya or gravity is trying to pull us down and to make us fall to earth. But our body, it resists. Our, axial skeleton and the muscles they attached with it, they try to protect us from the fall. So this is postural reflex. So in the human body, it refers to maintaining a stable position, whether stationary or moving. My dears, more difficult is this, that I am, moving now. Before I was standing and the gravity was pulling me, and my body's muscles, with the help of my nervous system, they were trying to keep me standing. I was sitting, the gravity was pulling me towards earth, but I was sitting because my back muscles, they were keeping me straight. Now, the difficult thing is moving. When we are walking, then how we do not fall, and how we maintain our balance if we are going up or we are going down the stairs, So we have got 2 types of equilibrium. One is called static equilibrium, which is maintenance of the body's position when it is stationary. Stationary means when it is stopped, when it is resting. The other is dynamic equilibrium, which is maintenance of the body's position during movement. So I am walking, and I lose balance and I maintain balance. This is dynamic equilibrium. Then I stop. This is static equilibrium. Starting from A, going to B, then going to C. A. We see, alhamdulillah. So VN helps us in balance. Most important, inner ear. We have got inside our ear angular and linear acceleration recording receptors. In the ear, can you believe it? Ear has 2 functions. One is hearing and other is balance. So ear records our movement, 2 types of movement, angular movement or linear movement. If we are going straight, yani from here to another place straight, or we turn right or left, this is simple. This is called linear. But if we are going in circles, Our head goes down, head goes up, like the pilot of Fadaiya. They are maneuvering their aeroplanes. Or we are going in a high-speed motorbike and we turn on the side. So this is angular motion. So there is record. And then, my dears, another important thing, our muscles have receptors, our joints have receptors, our tendons have receptors. Each joint of the body, each muscle of the body, each tendon of the body, from head to toe, they send the message. Now we have three things. Messages coming from the muscles, bones, and tendons. This is called proprioception and exteroception. Messages coming from our ear and messages coming from our eye. These three, they go into different parts of the brain: cerebellum, our brain stem, and our higher centers. They together, they control our balance in two type of responses. One, when we get disbalance, like this person was about to fall, he extended his arms and he extended his leg and he balanced himself. This is called reactive postural response. Yani, once there was disbalance, the person was able to balance himself. The other is this, that he has planned that I will run 100 meter in 9 seconds. And he knows that I am going to run straight and fast. How he maintains his balance and he does not fall, how he fights with the gravity, jazibiya. So this is called anticipatory. Yani, you anticipate, you expect that I will fall. And in this, you continuously make your postural adjustment when you are running. We are fighting against gravity. I repeat, you are not in space. In space, there is no gravity. But here we have gravity. Gravity is making us fall. It wants everything to come towards Earth and towards the center of Earth. So this is what this first line was. See, where opposing forces or influences are equal, yani gravity is putting a force and I am resisting the force. Muhammad Isa, if you want to get A plus, Muhammad Isa asked a question, is this picture with us in exam? I said, every picture is in the exam if you want A plus. For B plus, I will send the tutorial. Okay? Yani we give from here, what question can you make? Only this, that reactive postural response and anticipatory postural adjustment. There is this difference, that this is reflex and this is anticipatory. Yani we plan it. All right. So final about the equilibrium, we have got sensory system involved. This is inside the ear. This is inside our ear. This 1, 2, 3. These are called semicircular canals. Anterior, lateral, posterior. This is anatomy. They record our angular motion in 3 planes. We are not discussing this. This is for hearing. This is for hearing. But we discussed, this is called vestibular system. It is located in the inner ear. It detects head position and movement. And the key structures include semicircular canals, utricle, and saccule. So this place where they come and they meet, this is saccule, you see. And likewise, this is utricle. So this is utricle, this is anatomy. For physiology, this is enough that where is the receptor which is helping us in maintenance of the balance, and it records our linear and angular motion. I go back. It records our angular and linear motion. This is present in the inner ear. So underline this. This is present in our inner ear. Then we have got our eyes, visual system, which provide information about the body's position relative to its surroundings. We can see that I am about to fall. We can see that something is about to hit us. we can see that this road is up and down. Then we have got our muscles and joints and tendons. This is called somatosensory system. My dear Muhammad Isa, you asked the question. We have explained one, visual, two, from the vestibular apparatus in the ear, and three from the somatosensory. This is part A. So this part A we explained over here in this slide. So finally, there is integration of all this information which is coming from vestibular apparatus, visual system, and somatosensory system. See, we have now changed the topic. It is maintaining equilibrium and role of physiotherapy. Now, your patients will come who have lost their balance because their cerebellum is not working, their brain stem is not working, their eyes are not properly working, their ears are not properly working. So what will you do? Number one, all this information, it goes to the cerebellum. This is lam, not ra, not cerebrum, and brain stem, which integrates sensory information from vestibular, visual, and somatosensory system to maintain the balance. What are the two responses? The two responses are postural reflexes and voluntary movements. There is automatic response to maintain stability and prevent fall. I go back. Now we are explaining this. This is automatic postural response. So this is number one. Number two, voluntary movement. We think if I'll put my foot here, my balance will be fine. So we control the movement with the help of our higher centers, and we adjust and maintain our balance during activities like this person is anticipatory postural adjustments. Now, when a patient comes to you, the physical therapist, you improve their balance and coordination through exercises which target the vestibular, visual, and somatosensory system. We have exercises which help them improve the function of their ear receptors. We have exercises which help them improve their eyes and its connection with the brain. Or may Allah help, if someone does not have the VN, then how will he control the balance? So the physiotherapist helps them in learning techniques which include balance training, strength exercises, and proprioceptive training. Then we change our topic once again, and a very small topic, we'll not go into detail. Only one thing is left in the motor system, which is in the end, because it's not purely motor, it's not purely sensory, it's not purely autonomic, it's not purely endocrine, it's not purely vegetative functions. It has strange functions. It's a very small place in the brain, but it has so many functions that if you ask me, doctor, what do you think about ruh? Where is ruh? Where is our soul? So I will say probably Allah subhanahu wa ta'ala has put it in hypothalamus. I am not sure. But hypothalamus has every function in the body. It, except for moving our legs and to telling us where we are getting a painful stimulus, rest all functions are done by hypothalamus. It controls our hormones. Now see I'll quickly pass through this. It controls our body temperature. First semester, first lectures, homeostasis. We learned it. Our temperature thermostat is in the hypothalamus. Our appetite, ju', it controls our hunger. It controls our satiety, shaba, yani I am full, I don't want to eat. Our thirst, we have center for them in the hypothalamus. Sleep and wake cycle, circadian rhythm. This is now light. The birds, they start coming out. You don't see the birds in the night. The birds, they sleep somewhere in the trees or somewhere in the nest. As soon as the sun is out, they start speaking and they start flying and they start coming in the VN. We can see them. So what thing makes them sleep in the night and come up outside in the morning? This is circadian rhythm. This is also present in the humans. we are disturbing it ourselves. We are sitting on our laptops and our handhelds all the night, and we get our sleep disturbed. But normal circadian rhythm and our sleep pattern and our best level of alertness, it is called sleep-wake cycle. Who controls it? Hypothalamus. My dears, we have got, about 20 big hormones and as many small hormones which come from different places. You know the big names, you know the name of growth hormone, you know the name of oxytocin, you know the name of thyroid hormone, you know the name of cortisol, you know the name of insulin and glucagon, you know the name of, testosterone and estrogen and progesterone and follicular stimulating hormone and luteinizing hormone, and I missed maybe some of them. And then we have got the stomach hormones like gastrin, and we have got the intestine hormone like, enterokinase, and we have got so many other hormones. Subhanallah, hypothalamus controls the release of the hormones from pituitary gland, including growth hormone, thyroid stimulating hormone, and most of the other hormones. Hypothalamus controls our autonomic nervous system. It controls our heart rate. It controls our blood pressure. It controls our digestion indirectly by controlling the autonomic nervous system. Still, story not finished. Hypothalamus controls our emotions. It controls our laughing. It controls our weeping. It controls our getting angry. It controls our getting sad. It controls our getting happy. Stress, fear, pleasure, behavior, regulation of emotion is the function of hypothalamus. It maintains homeostasis. It controls our sodium level. It controls our potassium level. It controls our chloride level. It controls our glucose level. So homeostasis maintenance, indirect function of hypothalamus. My dears, we come to the final one. Part of the emotion and behavior is our sexual behavior and desire to produce. So ovulation in the female, it is dependent upon a hormone. Menstrual cycle of the female, it is dependent upon the hormone. And the hormones, they are dependent upon hypothalamus. Our testosterone and androgens, they come from different places, one from the testes and other from the adrenal gland, but they are in turn controlled by the hormones by coming from the hypothalamus. So our sexual behavior and reproduction, they are also controlled. Reproductive behavior, menstrual cycle, through the hormones which are controlled by the hypothalamus. A baby is near the birth. Fetus is coming out, delivery. Oxytocin hormone is required, which comes directly from the hypothalamus, and it is released from the posterior pituitary. This baby puts the mouth on the mother's breast and starts suckling, and the milk comes out of the mother's breast. This milk comes due to oxytocin, it comes down, and this is coming from the hypothalamus. So, my dears, hypothalamus has so many functions which we cannot even imagine. Very small area. My dears, we are switching over to the next part, and this is interesting. We'll have 2 slides, maybe for 7 diseases, which are directly related with physical therapy. We have discussed all of them in the previous 7 lectures. Here, we will just give reference to them, that what's the problem and what physiotherapy people they do. So some lesions affecting motor nervous system and role of physical therapy. Look, there is a difference between these two. She cannot stand, he cannot stand. But she can herself move her wheelchair. I hope you are understanding. He cannot move his wheelchair. Someone will push. She can hold her neck. He cannot hold his neck. Her arms are straight. Her legs are straight. But she cannot stand. She needs support. She is weak. Weakness is called paresis. he is not weak. He does not have muscle function. This is called shalal. This is called paralysis. So paresis, partial or mild loss of voluntary motor function resulting in muscle weakness. Example, it can be due to nerve damage or stroke or many diseases of the nervous system. If it is in half of the body, we call it hemiparesis. Half means one side, either right side or left side. Why not up and down? Because when we discuss the nervous system and the brain, I told you two words. One was contralateral, yani opposite side. Other was ipsilateral, yani same side. Right side of the brain controls the left side of the body. Left side of the brain controls the right side of the body. So this is what we are saying. If one side is weak, we call it hemiparesis. Again, it is common with stroke or the cerebrovascular accident, where a patient may have difficulty in moving one arm or the leg. My dears, we come to shalal or paralysis. Complete loss of voluntary muscle function in one or more parts of the body, often resulting from damage to the nervous system. This is the basic difference between paralysis and paresis. Now we go to the explanation of paralysis. May Allah help everyone and save everyone. It's possible that only one limb motor function is gone. Monoplegia. Wahid, monoplegia. It is possible that one half or one side of the body, it is not working. Hemiplegia. It is possible that some problem with the neck nerves, both upper limbs, they are not working. Very rare. Diplegia. It is possible that all the muscles below abdomen, they are not working. Or all the muscles below pelvis, they are not working. This is called paraplegia. And it is possible that all the things below the neck, not wahid, not ithnain, die, not thalatha. It is four, arba, quadriplegia, wahid, ithnain, thalatha, arba. So quadriplegia. So these are the types of paralysis. Monoplegia, hemiplegia, diplegia, paraplegia, quadriplegia. This was for understanding, and this is for the quiz. Hemiplegia, complete paralysis of one side of the body. It's different from hemiparesis, which is weakness. So this is hemiplegia. And be careful in the exam. Quadriplegia, also called tetraplegia, it is paralysis affecting all four limbs. If you break the spinal cord from here, all four limbs, they are gone. Monoplegia, paralysis affecting a single limb or muscle group. Monoplegia may occur due to localized brain injury affecting only one arm and one leg. We did not write here diplegia, which is two arms or two legs, but it is rare. We come to now serious topic. First disease, complete transection of the spinal cord. This boy, he got an accident and he broke his neck. Or this person gets a car accident and he was wearing a seat belt and he went suddenly front and his spinal cord broke. The rest of the body is perfectly fine. See, from here the spinal cord break. This is healthy. This is dead. This is healthy. This is fibrosed. This is having blood supply. This is suddenly cut off from the main spinal cord. Below this, below this cut, all the functions will finish. Above this, all the functions will be normal. So it depends which place. See this slide carefully. If it is here in the neck, cervical vertebra, we have given example of C4 injury. There will be quadriplegia. What is quadriplegia or tetraplegia? This is the diagram. All the four limbs have disappeared. That is why we have learned this diagram. So, quadriplegia, C4 injury, C6 injury, a little down, see a little down. Hands and arms as well as lower body, it's not functioning. And we go further down, thoracic segment, thoracic vertebra, T6 injury, T5 injury, T7 injury, thoracic vertebra. Paraplegia results in paralysis below the chest. That is why we define paraplegia. That is why we define paraplegia. He broke his back. He broke his neck. Breaking the neck or cervical vertebra, quadriplegia. Breaking the back, paraplegia. And finally, this is more lower down. Still, the legs are gone, but he has got the abdominal function also gone. He has got abdominal muscles working normally. That is why 20 slides back, I told you that there are even abdominal reflexes which the doctors, they check. So my dears, this topic is complete transection. Look at the word. We don't need to write complete, but this is for you to understanding. Transection means complete cutting of the spinal cord. Patient will develop complete motor and sensory loss below the level of the lesion with the return of bulbocavernosus reflex after some time. Put a mark over here. This is MCQ question, but we will explain it later. Definition, transaction. This I'm explaining the same thing. Total severing. Severing means cutting of the spinal cord leading to loss of all sensory and motor function below. Pathophysiology. Complete spinal cord injury disrupts all ascending and descending pathway. If the ascending pathways are blocked, sensory function gone. If the descending pathways are blocked, motor functions are gone, resulting in complete loss of motor and sensory function below the injury site. This leads to total paralysis and loss of sensation below the injury level, loss of bowel and bladder control. He cannot control passing urine. He cannot control the passing of the stool or defecation. My dears, role of physiotherapy is to maximize functional independence. We want the muscle not to atrophy. We keep on exercising these people in different way. We prevent the complications. We help them in making their life better. Good physiotherapists can make their small functions come back. At least they can be able to sit like this person in the wheelchair. This is big achievement. If a person is not lying in the bed and can sit like this in the wheelchair, this is better than lying in the bed all the time, you see. So this is the role. Techniques include range of motion exercises, strength training, and assistive device training. Now we come to a serious topic. What happens when a spinal cord is transected? If you cut the spinal cord like this one, immediately what will happen? The first thing to happen is called spinal shock. What is spinal shock? We discuss it in a minute, but all the functions of the body, they are lost and a person is in extreme distress. Then there is a recovery stage. Then there are long-term effects. And the long-term effects, they are finished muscle tone, finished flexor reflexes, finished plantar reflexes, which in the recovery stage, they come back and they become more powerful. Ankle jerk and knee jerk are affected. Urine passing and stool passing are affected. Blood pressure is affected. We discuss it. What is spinal shock? It is depression of all reflexes dependent on the spinal segments below the lesion. Now see carefully. Now all the reflexes, they disappear for some time. Flexidity, yani tone is finished. Retention, yani urine is not coming. Urine is in the bladder. It cannot come out. Just like you put more tea in a cup, it will start falling down. When the bladder becomes full, some urine starts coming. This is overflow. Likewise, the stool. It is not possible reflex to pass the stool. Blood pressure is reduced. This is called spinal shock. This is the first few hours after the transaction of spinal cord. Then we go to the recovery stage. Yani the person starts changing, recovery stage. Reflex activity becomes more powerful. This is called hyperreflexia. This shows that there is upper motor neuron lesion. If the reflex does not return, this means there is lower motor neuron lesion. So then there is spastic paralysis. That is, before in spinal shock, there was reduced muscle tone. Here, muscle tone is increased. So you can get a question, what about the muscle tone in recovery stage? So it is increased. It is not normal. What about the muscle tone in spinal shock? It is decreased. So please understand this. Motor and sensory functions, they will not come back. Khalas, they will not come back. You cannot repair the spinal cord. Mass reflex. You know, this is the most strange thing. Small stimulation at some leg or some knee or some abdominal region, sudden reflex of the body, immediately this person passes urine and stool and gets a lot of sweating and the blood pressure up and down. This is a strange thing which happens in the recovery stage, and the patient is in misery because they do not know, and the caregivers, they are in problem because suddenly all the intestines are empty, all the bladder is empty, there is urine, there is stool, the person cannot move, you have to clean the person. So this is a big problem for the medical profession to control them. My dears, we come to another topic. This was transection, complete transection of the spinal cord. Now, what happens if half is cut? You see, this half is cut, not full. This half is cut, and this half is not cut. For example, a bullet. For example, cancer. For example, someone, with a knife or khanjar puts it here and cuts the spinal cord, not full, but half. So, because the tracks go to the opposite side, so we have a strange picture. What is the definition of hemisection of spinal cord? What is the second name for the hemisection of spinal cord? What is the meaning of hemi? Hemi means nisf, and it is nisf section of spinal cord, not full. Its name is Brown-Séquard syndrome. It is damage to one half of the spinal cord. What is the presentation? Read carefully with me. Loss of pain, temperature, and light touch on the opposite side. Yani, this side is damaged. On the opposite side, pain, temperature, and light touch will be lost. And what will happen on the same side? Loss of motor function and vibration and position and deep touch sensation on same side as the cord damage. This is a strange case which helps us understand the function of the ascending and descending tracks. So definition, a neurological condition resulting from damage to one half of the spinal cord, leading to a unique pattern of sensory and motor loss. Pathophysiology, injury typically involves the lateral half of the spinal cord, causing ipsilateral, yani same side, motor weakness and proprioception loss, and contralateral pain and temperature sensation loss. Please write with your hand. Contralateral means opposite side. Ipsilateral means same side. This, if you read, this is enough for the exam, but this is detailed here. Weakness or paralysis on one side of the body, yani ipsilateral, loss of proprioception and vibration sensation on the same side, and loss of pain and temperature sensation on the opposite side, contralateral side. So everything is detailed here. Physiotherapy, improve the mobility, strength and coordination. Now it is very difficult. One side is moving, the other side is not moving. One side muscles are getting atrophy, the other side muscles are normal. So we help them this is our special training by which we help them have Yani how bad a person will look if he is sitting on the wheelchair and one leg and one arm, they are very thin, and the other, they are normal. See, so we try to make their life better by balance training, strength exercises, and functional mobility training. You know, the most common killer after the heart attack, if we do not consider cancer, the first is heart attack, the second is stroke. It kills, okay, khalas, the person is dead. But the second thing is this, that it makes shalal. Many people, they survive and they have got problem. Two causes, 15% they have got hemorrhage or bleeding in the brain. 85% they have got block in the artery, which causes no blood flow and death of some part of the brain. This is called ischemic stroke. Ischemia means no or low blood flow. This is called hemorrhagic stroke, which means there is bleeding. We can see them on CT scan. In this case, we try to remove the blood. In this case, we try to open the block, that maybe the brain function comes back to the normal. Definition: sudden interruption of blood supply to the brain leading to neurological deficits. Pathophysiology, two types: ischemic, which is blockage of blood flow, or hemorrhagic, which is bleeding, causes damage to brain tissue due to lack of oxygen and nutrient. What are the symptoms? Symptoms are paresis or plegia. Paresis, weakness or numbness, or paralysis on one side, face, arms, legs, difficulty speaking, VN problem, sudden headache. Role of physiotherapy: we facilitate motor recovery, enhance functional abilities, and improve their independence. We make them slowly come back. This is our big achievement if they come back in 6 months and at least they can sit and they can go to washroom on their own. It is our big achievement if in 1 year they start holding a spoon in their hand and they can eat the rice with their hand, you know. So this is with the help of physical therapy. If you leave this patient on his bed, he will just stay like that for the rest of his life, and the miserable life will be there. Techniques include range of motion exercises, strength training, and coordination exercises. My dears, this stroke and this hemisection of spinal cord and this transection of spinal cord, they were all mostly examples of upper motor neuron lesion. Now we have got an example of the lower motor neuron lesion. The disease is very famous. It is called poliomyelitis. It is by a virus, which is called poliovirus. This poliovirus attacks only one small area of the spinal cord and destroys it. Pathophysiology: poliovirus infects and destroys motor neurons in the anterior horn of the spinal cord, leading to muscle atrophy and paralysis. It is a viral infection that primarily affects the alpha motor neurons. Put a mark over here. This is simplest of the MCQs. What is the name of the disease that affects the alpha motor neurons in the spinal cord, leading to weakness and paralysis? So this viral disease is poliomyelitis. There is acute onset of fever, fatigue, headache, muscle weakness, or paralysis, particularly in the legs, loss of muscle tone. Now, why we learned monoplegia? You remember? Monoplegia. Monoplegia. That is why we learned it. Example of monoplegia is poliomyelitis. So poliomyelitis is monoplegia, localized paralysis. Then there will be muscle atrophy because it is lower motor neuron lesion. And I discussed it with you in the class in detail. Role of physiotherapy: we keep on giving exercise to this muscle, maximize functional recovery, maintain muscle strength, and prevent deformities. Techniques include range of motion exercises, strength training, and functional mobility training. My dears, we have got a strange disease. May Allah keep everyone safe. We do not know what is the cause. We do not know if it is due to a virus or it is due to some autoimmune disease or whatever. We do not know the cause. But what happens is this, that see, this is normal neuron and this is normal muscle. Normal. This neuron, it is motor neuron and it starts dying. When this neuron dies, this muscle becomes wasted. The name is amyotrophic lateral sclerosis, famous disease, amyotrophic lateral sclerosis or ALS. What happens? Progressive neurodegenerative diseases affecting motor neurons, leading to muscle weakness and atrophy. There is degeneration of motor neurons in the brain and spinal cord, resulting in muscle wasting and loss of voluntary movement. Now, muscle weakness, difficulty speaking, difficulty swallowing, problem with respiration. Role of physiotherapy: maintain function, prevent complication, and improve quality of life. Again, range of the motion exercises, assistive device training, and respiratory exercises. What is assistive device training? The person can move his wheelchair. We have got the biggest example, this one. Just look in the net, you will be surprised. He was a big physicist and cosmologist. Yani, he was big person in physics, not a small person, big name in physics. His name is Stephen Hawking. He got this disease at the age of 20. He made this wheelchair by himself. If you learn about him, he has got different devices. He could not even speak in the end. He could not walk. He could not sit. He could not do anything. But still he was giving different theories of the physics. Still he was teaching the students, not by speaking. He will use this. He has got a mic, small mic here. This device will understand what he is saying, and this will translate it on the screen. This, he will order his device and his wheelchair will move. So this is called device training. Normally, people do not live for 50 years. He lived with this disease for 50 years. Yani he got it at the age of 20 and he died at the age of 70 plus. So my dears, the disease name is amyotrophic lateral sclerosis. The question asked in the MCQ is generally about pathophysiology. Degeneration of motor neurons in the brain and spinal cord, resulting in muscle wasting and loss of voluntary movement. I'll put all these in small question forms in the tutorial and you will be happy with it. We come to another disease. Now it is becoming less in our countries, especially Muslim countries, because we do not have sex, alhamdulillah, outside our marriage. But those people who go to marriage, out of marriage sex, and many ladies, they never know that they can get a big disease which is transferred by sex, not AIDS. I'm not discussing AIDS. This disease is called syphilis. Syphilis. So from syphilis, sometimes this is a late manifestation in the nervous system, and it affects the lumbosacral dorsal spinal roots and dorsal column of this dorsal part. So what happens is this, that there is loss of the sensory system. You see, demyelination of the dorsal column and dorsal root due to chronic syphilis infection, leading to impaired sensory transmission. It is a late manifestation of untreated syphilis, affecting the spinal cord's dorsal columns and causing progressive degeneration. Severe pain, ataxia, difficulty to move, loss of reflexes, impaired proprioception. They do not know where to put their foot. They do not know how to balance themselves. So reduced joint position and vibration, hypotonic skeletal muscle. Physiotherapists improve their balance and coordination and function by techniques like balance training, coordination exercises, proprioceptive training, and pain management training. Otherwise, they cannot walk properly. They have got different types of gait abnormalities. This is one type of abnormality in walking, spastic gait. This is second type where both knees come together, scissor gait. This is third type where the person is like falling in front, propulsive gait. This is like this person is askari, like moving step up and down. This is called steppage gait. That is why they wrote steppage here, high steppage. And this is called waddling gait. So this different types of diseases. Firas, you can open your mic and give your comment. Why do you say they don't deserve treatment? I think in Arabic you said something else. Every patient, we have to treat them. We try to treat them. We try to help them. But they all are our patients, so we have to help them. But maybe in Arabic you said something else, and translation is a bit wrong. All right. So this is the last one, syringomyelia. Here, the colored area, it shows us a syringioma, a malformation, whereas fluid is coming here, So spinal cord, it is being pressed by this fluid. If we don't drain it, it presses on the spinal cord and it causes the motor functions to finish. We have to drain it again and again and again. Otherwise, the spinal cord starts dying. So, a disorder in which a cyst forms within the spinal cord, a chronic disorder where a fluid-filled cyst forms within the spinal cord. This is called syrinx. Syrinx. This expands and elongates over time. It becomes long, 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 damaging spinal cord tissue and disrupting normal cerebrospinal fluid flow, progressive weakness, pain, stiffness, and loss of sensation, particularly in the back, shoulders, and in the arms. Role of physiotherapy: manage symptoms, improve strength and mobility, and reduce pain. Techniques include strength exercises, pain management strategies, and functional training. This was the last one, but now I have got the explanation from Firas. He thought that because the previous one, a person got syphilis because of immorality, sex with, bad ladies. So he thinks that they do not deserve treatment. But this is not so. We have, if Allah subhanahu wa ta'ala is Ghafurur Rahim, and he can pardon us, we should think like this, that maybe when we treat them and they become fine, they will be making istighfar and they will become better people, So we treat everyone. We don't think of this is Yahudi, this is Christian, this is like that. We treat everyone. We treat everyone. This is the special thing in the medical profession. That's all from me, inshallah. You will receive the tutorial from me. There will be an assignment on the blackboard, which you have to do on the weekend. This assignment, 2 chances, like the introduction assignment. Saleh will send you the information when I put it on. Try to do it immediately, although I will keep it open for Friday and Saturday because assignment gives you good grades in the exam. And I have put 2 attempts for the assignment. This is number 1. There will be many questions, which you can do it with the help of tutorial and your slides. And likewise, we will have a good tutorial, inshallah, which will be small questions like before. And if you guys need further guidance, you can contact me directly or through Saleh, and inshallah I will be guiding you. This time I had, mashallah, many classes with you. And here we finish with the motor system. Thank you very much. May Allah bless you. And we will send you the slides, inshallah. And of course, the recording. Thank you. Jawad, yes, okay, you are here. Three students are missing. I don't like it. Everyone should be present. Okay, dears. May Allah bless you. You can now leave. Jazakallah khair. Best wishes for your exam and your life. Thank you for us.